Well, good morning. It's great to be here with you, all of you here, and all of you online. I'm excited to talk about my favorite topic, which is really, the neuromuscular perspective. When you're called to see a patient who's described as floppy, it's our job as neuromuscular specialists to figure out, is the child just hypotonic, or is there actually true neuromuscular weakness? So I'm going to try to give an overview of that. I'm going to try to be comprehensive, but more importantly, comprehensible. And I hope to leave some time at the end so we have time for discussion and questions. So the most valuable tools when you're assessing a newborn or an infant really are beginning with the family history, a good family history. And oftentimes we will look at the parents and sometimes even examine the parents. Obviously, clinical examination is important, but before that even is the observation of the infant or young child, and then the careful clinical neuromuscular examination. CK can be very helpful with the differential diagnosis. Muscle imaging, we love muscle ultrasound. It's part of our examination, so we examine the patient, and then we turn to the muscle ultrasound machine, and then we'll look at the same muscles which are weak. It's very, very helpful for pattern recognition and for our differential diagnosis, and we can use it also in newborns. Muscle biopsy still has a very important role. I know it's been debated, but we still love muscle biopsy. It can be absolutely essential in differentiating between certain variants you find in your genetic sequencing. EMG and nerve conduction, and also repetitive nerve stimulation or stimulated single fiber also have an important role, especially for hard to diagnose patients. And brain MRI shouldn't be forgotten because that can be very helpful, and I'll show you a few examples of that. So the important general points in the history really begins with when is the age of symptom onset versus first recognition. Many parents, if it's their first child, will not recognize any symptoms, and so you need to be very careful and kind of aim your questioning even for during the pregnancy. Was the mother concerned there was decreased fetal movement? That's a hugely important sign and often indicates that there's a congenital onset muscle disorder or a neuromuscular junction disorder. That's important. And many moms will say, I was dismissed by my doctor, but the baby didn't move, and that's very important. If the baby was breech, again, was not strong enough to get into the right position at the time of birth, another important sign. So again, we focus on, is this congenital, even prenatal, and symptoms evident at the time of birth, or is the onset of symptoms later? So very important for our differential diagnosis. And is the condition static, the same, or does it improve over time, or is it progressive? Are there episodes of periodic worsening? If so, what are those triggers? And then we have to kind of note what triggers are for the weakness. And are there any associated features? Is there children that are old enough to tell us, is there any pain? Is there any cramping? If so, what is the timing? Is it due to exercise, or is it all the time, or in the morning or the evenings? Is there any myoglobinuria? Very important clinical feature. And also always a good review of systems. Any hearing involvement, vision involvement, should we be thinking of metabolic or mitochondrial conditions? So take a good history and don't forget to ask about different systems beyond the muscle, because we need to have a wide differential diagnosis from the beginning. So again, the symptoms and signs of a neuromuscular disorder in early infancy would be the reduced prenatal movements, polyhydramnios. If the child has weak swallowing, they're not going to swallow the amniotic fluid, so there'll be polyhydramnios. Prominent facial weakness would be a point towards a congenital neuromuscular condition. Congenital contractures, fractures, and hip dislocation at the time of birth, again, very much pointing towards a neuromuscular etiology. Failure to thrive, dysphagia, aspiration, or even diaphragmatic eventration, a sign of a neuromuscular condition. And then obviously respiratory insufficiency because of the diaphragm weakness, intercostal weakness, or both. From the beginning, you want to do kind of an observation, look at the habitus of the child, and look for any dysmorphisms, kind of keen observation of any findings, facial features and whatnot. Look for any organomegaly, any cardiac involvement, very important, any pulmonary involvement, any autonomic features, and any skeletal or connective tissue features, which can overlap and be seen in conditions that are muscle conditions, but also conditions that are connective tissue conditions, and we'll talk about that. So for the motor examination, the general points are you want to really kind of focus on what is the pattern of weakness. Is there also any muscle atrophy or any hypertrophy? And if so, where is that? Is there a proximal predominance of weakness, or is it more distal, or is it mixed? Is it symmetric or is it asymmetric? Very important for your differential. Are there any focal abnormalities? In the very young child, the examination can be a little bit challenging. I'll show videos of that. The child needs to be, first of all, awake and alert, and hopefully not crying. I have videos of examples of both a happy child and an unhappy child, and it will affect your examination. And the key question for us as neuromuscular specialists, is it weakness or just hypotonia? How many times has a child in the neonatal ICU with Prader-Willi be confused as having a neuromuscular disorder? So observe, recognize the pattern of weakness and any atrophy or hypertrophy. There are many causes for neonatal hypotonia, so you have to keep that in mind when you go to see a patient. You're thinking about neuromuscular causes, but you must keep an open mind. And so the list is really too many causes to even include in one slide, but remember that acquired causes are more common than genetic. So think about the birth history. Was there hypoxia? Is there any chance there could be sepsis? Think about acquired conditions, then think about genetic, and then amongst the genetic conditions, central nervous system conditions are more prominent or more prevalent than peripheral nervous system conditions. So recognize that. It's not always going to be in our domain. And then amongst conditions, genetic and chromosomal are more common than normal neuromuscular conditions, which are more common than any inborn errors of metabolism. So we may have our neuromuscular hat on, but step back and think, wait, acquired or genetic, central or peripheral, and then keep going down your differential. So as we always like to do in neurology, localization. So where is the etiology localized in the nervous system? So think about things that would be really localizing to the brain or systemic conditions. So is the newborn having depressed alertness, not alert, not responsive to being touched? Are there lively reflexes, increased deep tendon reflexes? Are there any syndromic features? And you're thinking about asphyxia or hypoxia at birth, any congestive heart failure or any metabolic causes or sepsis, and then genetic syndromic disorders, or any brain developmental disorders, or any inborn errors of metabolism. So here's my first example. So say you've been called to the neonatal ICU to see this patient. So the first thing you do is observe, right? So you notice a few features are unusual. There's a prominent forehead. There's an upturned nose, a kind of a thick upper lip, a small chin, and then the arms are in extension and they're fisted. So more kind of syndromic, right? And so say the neonatal ICU team says, we did a brain MRI, and you see this, you say, wow, that's interesting. Any thoughts? It's kind of tough. We're not thinking primary neuromuscular, probably more of a genetic condition affecting the central nervous system. This happens to be Miller-Dieker syndrome, so chromosomal disorder, short arm of chromosome 17, 13.3. But again, here it's the observation, the dysmorphism, and the brain MRI where you realize I'm thinking of a genetic syndrome. This is a tough one. Again, you're called to see a patient. This is a patient we saw at Children's Hospital of Philadelphia, and some features you notice on examination: severe axial hypotonia, right? The subgravity neck flexion. You notice some facial features, right? The proptosis, and then the arms. The tone is abnormal. It's increased tone. Right? So you have elbow flexion, and the legs have increased tone. So central hypotonia, increased appendicular tone, hypertonia. And then the brain MRI, ventriculomegaly, if you can appreciate kind of polymicrogyria and kind of some cystic region as well. If I tell you the CK is 15,000 and you have this constellation, what are you thinking? Where should we be thinking in terms of what maybe subgroup of conditions? Dystrophinopathies, exactly, right? So you have, CK high would be muscle. The proptosis, the eye involvement in the brain, so kind of muscle-eye brain type of phenotype, and this happens to be POMT1 related alpha-synucleinopathy, the Walker-Wahlberg syndrome. We now use a gene nomenclature for naming the subtypes within the dystrophinopathies. And again, a huge differential. So when you see a child, you're also thinking of conditions that are non-neuromuscular that could cause brain malformations. So we move down to the spinal cord. So you're examining a patient, more uncommon in a newborn to have spinal cord involvement, but it can happen. Traumatic delivery. What you often see is as a really discrete level, a spinal cord level of involvement on examination for weakness, and also often initially depressed deep tendon reflexes and then very increased as time goes on, and take a very careful history. So acquire would be like a cervical cord transection. Moving down, we get down to the motor neuron, where we as neuromuscular specialists know that now we're in our area, right, the peripheral nervous system. And so with children or neonates with motor neuron involvement, you have normal alertness, very important to notice, absent reflexes, and often fasciculations can be appreciated on muscle ultrasound and on EMG. So acquired causes should still be considered. So there are some viruses that can cause motor neuronopathy, and that including enterovirus, and then of course the genetic causes, most common being spinal muscular atrophy and some other axonopathies. These are presenting as non-length dependent in their presentation. So it's not going to be more prominent distal weakness because it's a motor neuronopathy versus a neuropathy. So here is a kind of classical pictures. This is all pre any gene therapy or nusinersen or any therapy for spinal muscular atrophy. So the very narrow rib cage. Interestingly, the diaphragm is stronger than the intercostal muscles, which is different than many other neuromuscular conditions. And the severe, you can appreciate the severe hypotonia and weakness. Now moving on to the nerve, it's very rare in a newborn or to have really a peripheral nerve condition presenting in the neonatal period or in infancy, but it can happen. So you have, again, this kind of gradient, length dependent, so distal more than proximal, often arthrogryposis, absent reflexes. You will lose your reflexes uniformly in a neuropathy than you will not as uniformly in a muscle condition. So if you're seeing no reflexes, you're thinking more, is this a motor neuronopathy or a neuropathy? And then sensory involvement can be also appreciated. So acquired causes would be infantile CIDP or congenital Charcot-Marie tooth, congenital neuropathies. And this is an example of a severe form of a congenital hypomyelinating neuropathy. And you appreciate the distal versus proximal involvement in the distal contractures. And this is actually EGR2 mutation. So again, rare, but can occur, so it should be ion differential. Neuromuscular junction, tough to localize to often in a newborn or an infant, but it has to always be considered. So it can mimic a muscle condition, but think about if you see a child who has significant facial involvement, bulbar involvement, difficulty swallowing, could be fluctuations in the weakness, and often arthrogryposis. Very helpful sign can be you can have intact deep tendon reflexes, because that's not going to be presenting feature, a loss of reflexes, because it's often it helps in distinguishing between the muscle and the neuromuscular junction. So different causes. So acquired, so not to be ever forgotten would be, so fetal acetylcholine receptor antibody disorders, they're now been kind of termed FARAD, or FARAD. If the mother has antibodies against the acetylcholine receptor, the isoform, which has the gamma subunit, the child will be born with fixed weakness. But it's important to think about that and differentiate. If you test the mother and she has antibodies against acetylcholine receptor, then you can send off a specialized test to certain labs like in Oxford and Mayo Clinic, where they can test for, is the antibody specific to the gamma subunit, or the fetal isoform of acetylcholine receptor. The reason why it's important to recognize that is many of these children will respond to beta-2 agonists, albuterol or salbutamol. Other acquired causes of neuromuscular junction would be a pharmacological medication causing neuromuscular blockade, and then, very importantly, genetic congenital myasthenic syndromes, which often can mimic muscle conditions and can even have a myopathic EMG or a myopathic appearing muscle biopsy, but very important because there are treatments for the congenital myasthenic syndrome. Some respond to medication. So here's an overview of the congenital myasthenic syndromes. The ones in blue are the more common ones, probably you've seen patients with, so DOX7 or Rapsin or collagen Q. And the ones in red are more rare. But it's important to keep these in mind, again, because some will respond to medication. Other ones we're developing gene therapies for, but it takes kind of a keen eye to recognize it. In terms of electrophysiology, stimulated single fiber is abnormal, but not all centers do stimulated single fiber. So ideally, you want to avoid a muscle biopsy in this scenario because you're thinking about neuromuscular junction or differential. Here's some examples of genetic causes of congenital myasthenic syndrome that can cause a fetal akinesia presentation, a very severe presentation where the child is born with contractures and minimal movement. So you see on the left, this is Rapsin-related congenital myasthenic syndrome. And some features, again, this is a feeding tube, so difficulty swallowing, often respiratory distress, the contractures, often a very high arch palate as well. And on the right, you have Escobar syndrome, which is due to recessive mutations in the gamma subunit of the acetylcholine receptor, and really kind of that webbing of the joints. So keep in mind always that congenital myasthenic syndromes can present with a fetal akinesia or even an Escobar variant, but on your differential, there are other causes of fetal akinesia, so nebulin, LMOD3, LMNA, contactin. So not always neuromuscular junction, can also be muscle, but keeping in mind that there's overlap between the two etiologies. This is a patient we saw at Children's Hospital of Philadelphia, so you appreciate there's ptosis, there's facial weakness, he has a tracheostomy. So you're thinking this could be a congenital myasthenic syndrome, right? Yeah, and so he has actually a collagen Q-related congenital myasthenic syndrome. We're actually working on a preclinical model gene therapy for both collagen Q and DOX7-related congenital myasthenic syndromes. Now moving to the muscle. So in patients with neonates or infants with muscle involvement, there's often proximal more than distal weakness, as well as it can be global weakness. And the very helpful for differential is there facial weakness, is there extraocular muscle involvement, are there depressed reflexes? Again, they can be depressed, but they also can be normal. And acquired causes would be infantile myositis, rare but important to consider, and then genetic causes, congenital myopathies, congenital muscular dystrophies, and metabolic myopathies. So this is a kind of an area that our group focuses on, but to give you kind of an overview, it's a wide differential depending on, if it's an infant or a child or an adult, but keep in mind the differential is wide. So as Benedict mentioned, in adults, very common myotonic dystrophy. We see that in children in the congenital presentation. We focus a lot on the congenital onset muscle conditions, so congenital myopathies, congenital muscular dystrophies, as well as we see patients that present early with metabolic myopathies, and again, the mimic being the neuromuscular junction conditions, the congenital myasthenic syndromes. So thinking about congenital muscle conditions, so for congenital myopathies, historically we had used muscle biopsy, and the morphological features of the muscle biopsy were exceedingly helpful to figure out what gene we should sequence. But now we're in the age of next generation sequencing, but you still need to be the neuromuscular clinician, you still need to phenotype, you still need to know your differential, you still need to have that pre-next generation sequencing differential. Before you send the test, what are your thoughts? Probably should rank them, 1, 2, and 3. I'm thinking this, that, and the other. If you don't make your differential before you do the testing, you may have a whole bunch of variants and not know how to interpret them. So it's important to think from the get-go, what is this? And so for the congenital myopathies, the CK can be normal. And what's complicated too is over time, the same gene can cause different histologies, and the same histology can be seen in different genes causing congenital myopathies. But again, it's important to deeply phenotype and have your differential from the beginning. The congenital muscular dystrophies are an area that our team specializes in. They're rare but important and present often with CK elevation, but not always. And so the main subgroups within the congenital muscular dystrophies are the Marison or LAMA2 related dystrophies, collagen 6 related dystrophies, alpha-dystroglycanopathies, SEPN1 now actually renamed to be Selenon. Was called at times a myopathy, but really is a muscular dystrophy, and it has also been called rigid spine muscular dystrophy, and then LMNA-related congenital muscular dystrophy, and then the metabolic myopathy is more rare, but important to always consider, especially because there are treatments for some, including Pompe, and then not to forget also mitochondrial conditions. In children with mitochondrial disorders, it's going to be pretty uniformly recessively inherited nuclear genes involved, not a mitochondrial DNA mutation, because as the mitochondria age, they manifest symptoms. So mitochondrial DNA causative variants or mutations are often seen in individuals who present with symptoms over time. But if a child's presenting with liver involvement, brain involvement, muscle involvement, it's going to pretty uniformly be nuclear DNA. So you should find, ideally, a variant from your typical nuclear DNA sequencing. So the congenital muscular dystrophies, so in most centers in Europe and Asia, The most common form of congenital muscular dystrophy is LAMA2-related dystrophies or myostin deficiency. And here's an example of a patient we had seen. You see, this is a physical therapist demonstrating there's no evidence of elbow flexion, right? Severe weakness and severe axial weakness, no evidence of any neck flexion or effort towards neck flexion. Typically or historically, we would look at the muscle biopsy protein expression of myostin and divide patients between those who have no expression of myostin and those who have partial expression. But now we're not doing muscle biopsy as frequently. So we've kind of pivoted towards the idea of dividing patients between those who achieve as a maximal motor milestone the ability to sit, even if they're sitting propped up with pillows. But if you can get kind of like SMA, we're trying to do that kind of approach of a clear-cut phenotypic classification. If you can sit and remain seated, even with support, that would probably be one subtype, and those that actually attain the ability to walk independently, a different subtype. And that's important both for clinical care, but also for preparing for future clinical trials. And there are many therapies in development for LAMA2-related dystrophies. So in the form that has no myostin or expression, there's severe hypotonia. So this little infant on the left has complete myostin deficiency. He had a muscle biopsy and severe hypotonia, and typically independent walking is not achieved, but again, sometimes patients with no myostin expression achieve some ambulation, so again, we're using more of a maximal motor milestone classification. One helpful hint, newborns often have arthrogryposis with thumb adduction at birth and can be helpful, and over time they develop severe joint contractures. There's also often a motor, if you look, a motor neuropathy. And so those patients that have a milder presentation, they're often first found to have the motor neuropathy. It's not severe that it's seen in all patients who have early on a nerve conduction study, but keep in mind, if you have a mild patient with partial myostin deficiency, they can present with the motor neuropathy, and 30% will have seizures, often complex partial seizures. Now, this is a classic finding. We see the deltoid muscle as a pattern recognition. The deltoid muscle is often involved to the extent where there's no anti-gravity deltoid movement. And that can help us when we're trying to distinguish between infants that have different muscle conditions. So you see this little one's trying so hard to reach for the pen, but she doesn't have anti-gravity deltoid strength. And that's a very common pattern in LAMA2 congenital muscular dystrophy. And here's another patient a little bit older, and you see some kind of a little bit of a temporal muscle wasting. Again, a common sign, as well as often large head circumference as well. Very importantly, at my brain MRI, when it's done in a newborn or an infant, you'll see white matter findings. So abnormal appearance of white matter. This does not equate with any problem of the white matter. It's the water content of the myelin that makes this appearance. It's also important to note that many patients will have very subtle but evidence of polymicrogyria. Often the occipital lobe can also be the temporal lobes. And that's important to note because those children that have the polymicrogyria are more predisposed to have epilepsy and may have some cognitive involvement. But most commonly, the white matter involvement does not equate with any intellectual involvement, and we have patients that are getting their PhD as adults and do quite well.
Okay, good.
So this is the collagen 6 related dystrophies. Is probably often tied for the most common or second most common, and there's actually a spectrum of presentations. The classical described phenotype from Professor Otto Ulrich in 1930 is this congenital presentation. Nothing else quite like it. So once you've seen it once, you'll never miss it again. So this, you see evidence of this kind of forward rotation of the shoulders where the pectoralis muscle inserts as there's tightness, so the shoulders are anteriorly located. There's torticollis. There's severe distal hyperlaxity, and often there's hip contractures at birth and elbow contractures, and often kyphoscoliosis. The skin has a keratosis pilaris and keloid type scarring. So all of this constellation of symptoms points towards collagen 6 related congenital muscular dystrophy. And here's very kindly from a family, a newborn photo. Again, so if you see a child who has the dorsiflexion severe, so the dorsum of the foot is flush against the shin, think collagen 6. And again, distal hyperlaxity evident from the get-go. And then even early on, this infant I had seen at age 9 months had evidence of end-range knee contractures. So contractures proximally, distal hyperlaxity, think collagen 6. It is a spectrum, and so our colleagues in the Netherlands had described 1976 what they termed a dominant myopathy. Now we know it can be both dominant and recessive, and we're calling it now Bethel muscular dystrophy. What's important is it's not only seen in adulthood, it can be seen if you're astutely looking symptoms in childhood. So slip through on vertical suspension and W sitting can be subtle but important signs of Bethlem muscular dystrophy. And then there's more progression over time, but keep it in differential in a young child, and try to not forget that it's the milder form of the collagen 6-way dystrophies. It's also an intermediate form as well. And we worked on actually using maxillomotor milestones from infancy and childhood to predict the future phenotype. And so those children that never arise from the floor are going to be overweight congenital muscular dystrophy. Those children that arise from the floor with help of furniture or help of a parent are also overweight congenital muscular dystrophy. Those children that arise from the floor with no one helping them tend to then be the intermediate form of collagen 6-way dystrophy, and those children that attain the ability to climb stairs are Bethlem muscular dystrophy. SEPN1 or selenon-related or rigid spine muscular dystrophy. Important to note, there's poor weight gain and is part of the phenotype. So difficulty gaining weight despite the caloric intake, and an early need for non-invasive ventilation, even while ambulatory. So I think some pulmonologists think about children in wheelchairs, like in Duchenne muscular dystrophy. Once a child's not walking, needs non-invasive ventilation. These children need non-invasive ventilation early on. So when you see this degree, you'll see here in the video, of axial weakness, always think also, is the diaphragm weak? In this case, yes, it's also exceedingly weak. So you have a child with severe axial weakness. What's so profound is that she can actually do a little bit of a jogging type of run. So she's ambulant, but there's axial weakness and severe weakness of the diaphragm. And the muscle can have these very interesting Mallory body-like inclusions and oftentimes multi-mini-core. And this very interesting kind of lateral shift type of scoliosis where the hips and the shoulders are kind of shifted. It's very much a pattern from selenon or SEPN1. And then if they do truncal flexion, a very stiff, kind of rigid, straight lumbar area of the spine. LMNA-related congenital muscular dystrophy, very important, also very recognizable. So if parents even send you a photo, years ago there was a family in Russia who had made a website of their daughter, and they chronicled her progression. And I saw the dropped head, and it mentioned the genesis, let's check for LMNA, and it was LMNA. So this is a classically recognizable phenotype. It's a severe phenotype. So LMNA causing congenital muscular dystrophy is uniformly de novo. And it presents with a drop head, which actually occurs and is progressive over time. So usually, initially, infants have the head control, and over time, by about age 2, the head is severely dropped. There's poor weight gain. There's very early dependence on non-invasive ventilation. And the most important take-home message of all is these children that present with the congenital muscular dystrophy subtype of LMNA will uniformly need an implantable cardiodefibrillator, no matter what the local cardiologists may think would be sufficient to control the rhythm. A pacemaker is not sufficient. We know that because children have died with pacemakers. They have an atrial arrhythmia, which is very severe. And they usually need that ICD placed by approximately 10 years of age in our international cohort. But make sure that you share that with the local cardiologist, because sometimes they're not as familiar with how severe these atrial arrhythmias are. Here's a young child demonstrating the pattern of weakness. So you see the hip flexion is quite good, right? So hip flexion is quite strong, but severe axial weakness. And then here you see, again, too, a strong hip flexion, often a severe lordotic posture as well in the dropped head posture. And one thing also to note is many children are undergoing link monitoring or loop monitoring, implantable continual Holter monitoring to monitor them for long periods of time, and they will often catch these pauses, like 2 or 3 second pauses, and the parents will note like he or she was quiet. Well, that's a pause in the heart rhythm. So very important to be very proactive with the cardiac care and very proactive with the non-invasive ventilation. Okay, signs, symptoms, muscle disorders in early infancy. So observation, you may see a frog leg-like posture. Look for a pectus excavatum, very common in congenital muscle conditions. And look to see, are the shoulders and arms anti-gravity or are they subgravity? Is there a subgravity deltoid? You were thinking about Lama 2 maybe. Traction response, look for head lag, look for shoulder position, look for any flexion at the hips and knees, the ankles, perform ventral suspension, see does the child have any strength to lift the head, or are they kind of in a C shape, and I'll show some examples. On vertical suspension, is there slip through, another sign of weakness and hypotonia. And you also try to help the child roll and pull the leg first and see if the arm follows, or pull the arm first and see if the leg follows. Looking for, again, signs of discrete muscle weakness. And then also pulling at the legs, see if the children will flex at the hips and the knees. And I'll show some examples. So here you can see also on vertical suspension, slip through. And here you can see actually these little pectoralis folds, again, a sign of weakness. Abnormal ventral suspension, and abnormal scarf sign too. So all subtle signs that are important in the neuromuscular examination of the infant. Here's a traction response. So on top is a normal traction response, and then we saw before a patient with Lambert-2 related congenital muscular dystrophy, severe weakness, axis weakness, and also arm weakness. All right, so I'm going to show a bit of this video. This is actually the CHOP and 10 scale being done in the neonatal ICU. The child is awake, and during, I'm going to fast forward here, during the examination, the idea is for the physical therapist to kind of isolate certain muscle groups. And there is, in this child, evidence of not only low tone, but also there's evidence of decreased muscle weakness. So you see that with hand grip, and then later on, the physical therapist is trying to do this, again, to turn the arm while the legs follow, and isolating muscle groups so you can actually, I'm going to put it here, appreciate, is there anti-gravity hip flexion? Is there anti-gravity knee extension? Again, all trying to differentiate, is it just hypotonia or is there weakness? So if I tell you that's the muscle biopsy, this is a male infant, what's your differential? What's higher differential? I'm sorry? Central nuclear, and more kind of, if you kind of narrow in within the central nuclear myopathies, a male infant, myotubular myopathy, that's what this is actually, yeah, so very important to recognize and to diagnose. Another infant, this one I'm glad the volume is off because the entire assessment is actually yelling for his mother, which is really tough. But you can appreciate there's a pectus, a severe pectus, and again, the same scale, trying to see is just hypotonia, is there actually also weakness of certain muscle regions, trying to see is there anti-gravity here, trying to see is there anti-gravity quadriceps strength for knee extension. And if I tell you this is the muscle electron microscopy, ultrastructural findings of rods. So what are you thinking? Nemelin, exactly, Nemelin. Okay, so in general, there's a spectrum of phenotypes. Most common are typical congenital presentation for congenital myopathies, congenital muscular dystrophies, but you also can get severe congenital, the fetal achinesias. You can get intermediate congenital forms, you can get childhood onset, you can get adult onset. So keep your mind open that there can be, a spectrum of phenotypes, but also genetically a spectrum of causes. So here, for example, with Nemelin myopathy, think about it when, on a differential, when you obviously if you have muscle and you see the benefit of seeing the rods, this is trichrome, so evidence of rods here in trichrome, and also ultrastructurally rods. But if you don't have the muscle histology, you have an open mouth posture, you have this severe kind of axial weakness, maybe a pectus, you're thinking about diaphragmatic involvement, and often shoulder and arm weakness is more than pelvic and leg weakness, you should be thinking about Nemelin myopathy. Now this is RY1-related myopathy, which can occur in two forms. The autosomal dominant form causes central core disease. You can see the cores that are beautifully shown here longitudinally, but also these beautiful central cores. But if you don't have the benefit of the histology, it should be in differential, presenting with typically proximal weakness and a family history. Often a parent actually has proximal weakness as well, and the mother or father may not have recognized it. So the autosomal dominant form causes central core disease. We'll talk about later the recessive form, which causes central nuclear myopathy. And so it's a little bit complicated. But for the dominant form, central cores and proximal weakness, often a pectus as well. So in the general examination, we're looking at habitus and dysmorphism, also looking for any organomegaly, any cardiac involvement, pulmonary involvement, autonomic features, and skeletal connective tissue involvement. For habitus and dysmorphism, recognize dysmorphic syndromes associated with hypotonia and weakness. I mentioned before Prader-Willi syndrome. There's actually a cohort of patients that had simulated single fiber performed in London, and actually it was abnormal. So that can be misleading. So these patients with Prader-Willi, sometime early on their workup were thought, could it be congenital myasthenic syndrome? But keep in mind, Prader-Willi has other features as well, and so don't go down the route of muscle until it really is enough evidence that it truly is a primary neuromuscular condition. Trisomy 21 can also have hypotonia early on, mentioned before Miller-Dieker syndrome, and then lissencephaly is the ARX-related diseases. So recognizing faces can be a really helpful approach for differential diagnosis. So this is called the whistling face. Here on the left, the whistling face syndrome. In the middle, a hypotonic mouth. And on the left, kind of a different facial feature, kind of more stiffness. So any guesses on any of the causes for any of these faces? Yeah. Actually, Schwartz-Jampel, which one? The one here or one there? Yeah, actually, Schwartz-Jampel's great guess. So Perlecan gene at HSPG2 is the one on the right. How about the one in the middle? Any takes on this? What's that? Myotuber, I heard, yeah. Myotonic dystrophy, also differential, exactly, very important, very important. This one over here on the left, it's actually Freeman-Sheldon syndrome, MYH3, or myosin heavy chain 3. It's a tough one, but if you see that face, you should think about that. The middle one's myotuber myopathy, MTM1-related myopathy, and the one on the right is Schwartz-Jampel syndrome. So it can be helpful, the faces can be helpful. The one in the middle, of course, differential with myotonic dystrophy. Both are central nuclear. One, though, has myotonia on EMG. Okay, moving along. So looking at the general examination, you have a large tongue, a child who's trached invented. What if I told you the child also has cardiac involvement? What are you thinking? Yeah, Pompe. Very important. Treatments are available, so Pompe disease. So look at the whole patient, not just the muscle, and think about differential. So special considerations, cranial nerves, so facial movements, a smiling face, a crying face, anitosis, eyelid burying, look at extraocular muscle involvements, and also quality of speech and swallowing. So differential for extraocular muscle involvement, think about myasthenia, mitochondrial disorders, oculopharyngeal dystrophies, congenital myopathies, congenital aplasia, it's rare, of the extraocular muscles, but should be considered. So I'll go through some of these hints. So here, again, we have an open mouth. We have a child with a G-tube, a little bit of a slight pectus, and axial weakness. So any thoughts on this? You think it's a congenital muscle condition? Nemelin? Yeah, Nemelin myopathy, exactly. So think about the axial involvement. We showed that one in the middle before myotuber. How about the one on the left? So Benedict mentioned this during his talk, the fish-shaped mouth. So the two are similar, but what's that one on the left? If it's not myotuber, it's myotonic dystrophy, exactly. How about the one on the right? The poor little one's his whole shirt is wet with drooling. I'm sorry? I think someone said it. Yeah. Yeah, Nemelin myopathy. So oftentimes the open mouth and the drooling, not just for Nemelin, but it's axial involvement, so it kind of helps your thought process with a very hypotonic mouth. Others to consider would be severe RYR1, like the congenital onset and severe RYR1. Often the recessive RYR1 can be more severe. Other central nuclear myopathies, and also severe infantile FSHD. You can have a hypotonic mouth, so keep the differential open. Okay. And then this is a review and repeat from the last lecture. This one you should recognize from a mile away. FSHD, yes. And children always screen for eye involvement in hearing involvement, so Coast disease, the eye, and sensorineural hearing loss. And here, the mother and the two children have a similar mouth. Yes, myotonic dystrophy, exactly, very good. And then one more here. So this is not a severely affected boy compared to the infant we saw before being examined, but the histology here you see central nuclei, but it's a male who has extraocular movement involvement, central nuclei. This one's actually a little bit tougher, but a milder phenotype of MTM1-related myopathy. With central nuclear myopathies, often the extraocular muscles are involved. So here's an example of a really precious patient we saw whose parents never recognized that she wasn't actually looking much off midline because she so astutely turns her head looking at toys. But we realized in clinic, she's not really moving the eyes that much. She's absolutely adorable, but she's not moving the eyes that much. So if I told you that this is her muscle, so extraocular muscles are not moving much off midline. You have central nuclear histology. You also have some mini cores there on the NADH. You also see some on the electron microscopy, some streaming, so indicating the core-like regions. So, any thoughts? Yeah, RYR1 recessive is really important to always think about because it's a central nuclear histology. Extraocular muscles are involved is your really important hint to recognize that it's actually RYR1, the non-dominant form, because the dominant form we show had the central cores. So the key hint is the extraocular muscles involved. Here's a very severely affected infant who has trach-invented severe facial weakness. So we're thinking probably congenital muscle condition. I'll give you more of it. Oops, sorry, I give you the answer. But it's actor 1 Nemelin myopathy. So within the Nemelin myopathies, there are many genes that cause Nemelin myopathies. It's important to remember there's also a spectrum of phenotypes. We've seen actor 1 patients that have a very severe, even infantile fatal form, who often have actually on EM these cytoplasmic bodies, but also can present with a severe weakness and ventilatory dependence. Very important to note, and a colleague of mine will present at the Congress, there can be severe cardiac involvement that can require cardiac transplantation. So keep that in mind and be very proactive in screening cardiac function. Oh, here we are. So I should have shown the histology first. So yes, the Nemelin rods on trichrome. Okay, getting close to the end here. So very helpful exam findings. So if you have ophthalmoplegia in an infant with neuromuscular disease, think about MTM1, Dynamin 2, autosomal recessive RYR1, BIN1, those are, and congenital myotonic dystrophy, those are all central nuclear histology and nuclear myopathies. Think of multiminicore disease because RYR1 recessive can also have multiminicore as well as being central nuclear. Think about MYH2, also can have the MYH2 patients that are recessive can have ophthalmoplegia. Think about congenital myasthenic syndromes, especially the epsilon subunit of the receptor. And then again, mitochondrial disease, although rare in young infants because the extraocular muscle involvement happens with mtDNA mutated patients, which are usually present over time. And then don't forget infantile botulism can also involve the extraocular muscles and cause ophthalmoplegia. Oops, sorry, just so you can see this little video. So usually what we use is some sort of colorful tool or a pen and hold the head still because kids are really great just following with their head. They're looking wherever you are, but you want to really fix the head gently and then make sure you see the extent. One thing to mention as an aside is Meristin deficiency or Lambda 2-related dystrophy. There's a decrease of the upgaze, so that's also a notable helpful sign diagnostically. Okay, almost done. Tendon and connective tissue disorders can really mimic muscle conditions. There's hypermobility of the joints, there's hypotonia, there can be kyphosis, kyphoscoliosis, there can be skin involvement, can be also other organs that are involved. So you think about the hereditary disorders like connective tissues and some overlap myopathy syndromes. And Professor Nicole Wormans is the expert in these overlap myopathy syndromes with the connective tissue disorders. So I'm not sure we have any guesses, but I'll help this along because we're getting low on time. This is ovaric congenital muscular dystrophy, distal hyperlaxity, kyphoscoliosis, distal hyperlaxia. It's FKBP14, often associated with hearing loss, but not always. And the one on the far right, which is Nicole's paper, is kyphoscoliotic Ehlers-Danlos type 6. So think about the overlaps and try to recognize, is it muscle or is it connective tissue? And finally, I will skip this because that's going to be Jordy's talk on muscle imaging. So muscle imaging can be very helpful for pattern recognition for ultrasound and MRI. And just one point, just be sparing of the rectus femoris is very well seen on the ultrasound, but also can be seen in MRI, helpful at bedside if you're seeing a patient and you see the rectus femoris is spared. And also you can have sparing of the rectus in Celenon, but also you have a sparing of the gracilis and adductor longus. Okay, so we have that patient before, the recessive RYR1, decreased extraocular movements, sparing of the rectus, RYR1 recessive. And then finally, last but not least, muscle biopsy is still really important to recognize different morphological findings such as Nemelin rods, cores, central nucleation. CFTD, really important to note, CFTD is not a diagnosis, it's a pathological description of congenital fiber type disproportion. If you see that pattern of more type 1 fibers that are hypotrophied or smaller than type 2 fibers, you should have a differential in your mind about what myopathies cause that CFTD pattern. So that's actually RYR1, ACTA1, Titin, collagen 6, TPM1, TPM2, TPM3. So again, if you have the histology findings, think about differential. And then we can use immunostains to stain for protein expression for laminin 2 and 1 or meristin, alpha-dystroglycan, collagen 6, and also metabolic myopathies. It's very helpful to have muscle tissue for metabolic myopathies, looking for glycogen, lipid, abnormal COX and SCH staining. It's not useful to have muscle biopsy for central hypotonia, congenital myasthenic syndromes, and congenital neuropathy, so try to avoid going down the road of muscle biopsy if you're thinking about any of those etiologies. So just to demonstrate again, nemaline myopathy, core myopathy, central nuclear myopathy, and this is the fiber type disproportion. These are images from Professor Caroline Suri. And last but not least, EMG has a role as well. We like to use EMG when necessary for neuropathy or neuromuscular junction, but we also love muscle ultrasound. We can see fasciculations on muscle ultrasound. We can see patterns that look neurogenic on muscle ultrasound. We can see myopathic patterns on muscle ultrasound. So there's utility of using EMG nerve conduction. Often it's helpful to have muscle imaging findings as well. And then last is the brain MRI. So in children that have dystrophinopathies, the brain MRI is very helpful. So if you see abnormal brain MRI, you have cystic lesions here in the cerebellum, in particular megaly, hyperplasia of the pons. You think about, especially in the setting of a high CK, Walker-Warburg syndrome, muscle-eye brain disease, Fukuyama, congenital muscular dystrophy. Again, they're all named now from their gene nomenclature. So there are many genes now that have been recognized that cause dystrophinopathies, so they're now gene-related nomenclature. And that is the end of my slides, and I think I may have a few minutes for questions. I hope. Yes. Thanks.
Absolutely amazing talk. I think this was an atlas of neuromuscular congenital forms and the differential. Questions? So please wait till the microphone is coming to you.
Hello, thank you. Thank you for the great talk.
Thank you.
Just a question on, these days we have the genetics is easily available. What's your indication for doing muscle biopsies? And then the second question leading on that, if you find an ACTA1, would a muscle biopsy help to further subtype into nemaline or something? And will that help in the, for the prognosis and cardiac transplantation, etc. mentioned?
Both great questions. So what's the indication for muscle biopsy? So I think oftentimes we try to get a discrete differential from the examination in the history and the CK. Muscle biopsy can be helpful for multiple reasons. I would say sometimes it's a research reason. So if we don't have an etiology from genetic sequencing and we want to have the RNA from the muscle because the potential genes that we see variants in maybe not have been described yet, want to validate a variant in a new gene, but that gene we know has high muscle expression, we'll look at the RNA from the muscle. So we'd like to have our RNA extraction, but also for immunohistochemical stains can be very helpful. I think our colleagues that do metabolic myopathies, like Professor Ros Quinlivan in London, always says metabolic myopathies is exceedingly helpful. And then also, even with dystrophinopathies, when I was in London, we were doing muscle biopsies to have it for the research purpose of when it's a complex or new variant to see the level of expression of dystrophin. In terms of ACTA1 related myopathy, I'm not sure that the muscle would be helpful, actually, because it's complicated. We don't really see a correlation between maybe the load of nemaline rods and severity of symptoms. And I think it's an evolving story with the cardiac involvement. And it's a small gene, so ideally you should capture a causative variant in ACTA1. But the histology can be very helpful, but you need to use it in combination with your examination and your history. For example, just thinking with Titan, which is complex and often has multiple variants on our next generation sequencing, the histology can be central nuclear, could be CFTD, congenital fiber type disproportion. It could also have multi-mini cores, and so there's not a one-to-one correlation between histology. But with Titan, we've actually recognized the newborns have the same positioning. They are often born with their arms externally rotated and their hands in a position of wrist extension. So opposite from the collagen 6 patients. So there are patterns we're looking at too. So muscle biopsy helpful if we have many variants to interpret, and helpful from a perspective of having the RNA, and for immuno, for complex either new variants or new genes being validated. Or if you don't know what's going on, you have no etiology, it's helpful to have that muscle tissue.
Thank you. So, sorry, just one question. Can I ask another question on On the LMNA, how often what's your cardiac surveillance? How often do you the Holter and monitoring?
It's a great question. So the team in Barcelona have done a beautiful study looking with the loop or the link monitor. I think the idea would be what we do often, the cardiac evolves over time, and usually they need ICD by about age 10, but we do annual halters in the infants, and then try to get, if we can, implantable loop or link monitor to do kind of a long-term monitoring. And there's certain biomarkers of that atrial, kind of a lot of PACs, premature atrial contractions, which you or I could have and no one would be worried about. But in a child with LMNA-related CMD, if there's a lot of PACs or any pauses on the long monitoring. So initially once a year, but I'd say after age about 3 or so, we try to do, if we can, extended Holter monitoring to be really proactive.